Hello everyone, you're very welcome to this webinar. My name is Kathleen Bennett and I'm Head of the Data Science Centre here at RCSI School of Population Health. It's great to see so many interested in our webinar series on chronic diseases in Ireland. In this fourth webinar in the series, we'll be focusing on tackling social inequality in chronic diseases. In the first webinar, we heard about the epidemiology and policy issues relating to chronic diseases from both an international and national perspective, and the challenging impacts for those who live with chronic disease. In the second webinar, we examined prevention of chronic diseases, and we heard how both primary and secondary healthcare play important roles in this. In the third webinar, we focused on treatment of chronic diseases and heard about challenges and conducting health economic evaluations of chronic disease interventions. In this final fourth webinar, we focus on how to tackle social inequalities in chronic disease. We have invited three very interesting speakers and our moderator, Dr. Ronan Glynn, to guide us through this session. If you missed the previous webinars or want to revisit them, you can find them on our School of Population Health webpage under the Health Outcomes Research Centre. I will let Dr. Glynn, our moderator, do the introductions to our speakers. After the three presentations, there will be time for a panel discussion. I will encourage you to submit questions in the chat function so our moderator can use these during the discussion with our speakers. I want to thank all the speakers for their time and willingness to take part in this webinar. And I'd also like to thank the organising committee, which consists of Dr. Ronan Glynn from EY Ireland, and my colleagues Brian Lynch and Professor Jan Sorensen from the School of Population Health. I'd also like to thank Johnson & Johnson and Novartis for their support of this webinar series. So I'd like now to introduce our moderator, Dr. Ronan Glynn. Dr. Glynn is the sector lead from EY Ireland. Previously, Ronan was the Deputy Chief Medical Officer at the Department of Health, and Ronan has been our moderator for all the webinars in this series, and he was the moderator for our webinar series last year. And we're very grateful to you, Ronan, for taking on this role, and I'll hand over to you now. Thank you.
Brilliant, Kathleen. Thanks very much, and good afternoon, everybody, and welcome to the fourth and final in this year's series of webinars. So as Kathleen said, the kind of focus over this year has been on chronic disease, and in the first webinar we focused on prevention and looked at policy interventions and supporting prevention. And then in the second and third webinars, our speakers discussed how to achieve better outcomes for those living with chronic disease. We discussed implementation of the HSE's integrated model of care for the prevention and management of chronic disease and its impact to date. And then we took some time to consider the evolving landscape for diabetes and dementia in a bit more detail. So today, the topic for our webinar is tackling social inequalities in chronic disease. And I'm delighted that we're joined by three fantastic speakers, Professor Susan Smith of Trinity College, Dr. Sheelah Connolly from the ESRI, and Helen Gaynor from the Irish Heart Foundation. So I'll shortly introduce Susan, but just a reminder to everyone again that if you do have questions that you want to ask, please pop them in the chat box, and we will try to come to them at the end. So the format for the session is three 20-minute presentations, followed by hopefully about 15 or 20 minutes for questions and answers with the speakers. So with that, we're going to start today with a presentation from Professor Susan Smith. Susan's a professor of general practice at Trinity College Dublin, and she works as a GP at Inchicore Family Doctors in Dublin 8. She's also the Associate Director of the HRB Primary Care Clinical Trials Network Ireland and the Clinical Lead for HRB CISR, which provides evidence synthesis supports for the National Clinical Effectiveness Committee. She's also an Honorary Clinical Professor in the Department of General Practice at RCSI. And today, Susan's going to talk about general practice at the deep end. So Susan, thanks very much.
Thank you, Ronan. And thanks for the slide. So you could probably move on to the next one, please. So just to start off, I don't have any financial conflicts of interest, and my only kind of conflict of interest is that I am a coordinator of Deep End Ireland and I'm a GP, so I do have that bias as I go into this topic area. So today I'm going to give you a brief overview of the impact of poverty on health and health systems. I'm going to tell you a bit about what the Deep End concept is, look at some of our experience with advocacy, and then finish up looking at some choices that we have around policy and potential solutions to address health inequities. So next slide, please. So many of you who are involved in health inequity will often think of inclusion health, and that I just want to make a distinction between the very important area of inclusion health, which really focuses on very disadvantaged groups, for example, people experiencing homelessness, whereas actually poverty in our health system has a far wider impact. And that's where the Deep End idea comes in. So most people who are poor in Ireland are actually living in urban deprived settings and are attending GPs and are using other parts of the healthcare system. We know that people in the most disadvantaged communities have a 3 to 4 year shorter life expectancy, but really critically, they spend an 18 to 19 years more in years lived in poor health. We also know from Scottish data that they develop multiple long-term conditions or multimorbidity about 11 years earlier than those in the most affluent groups. And we also know from lots of life course and longitudinal data that it has impact across the lifespan. So people who experience adversity in childhood, that has a direct impact on multimorbidity, both physical and mental health conditions in adulthood. And at the moment, based on recent report from the SRI, there are 250,000 children under 5 and their parents living below the poverty line. So there's a lot of people who are experiencing poverty that leads to significant impact on their health. Next slide, please. So again, you'll be familiar, many of you, with the inverse care law. This is a term that was coined by a GP in the Welsh Valleys more than 50 years ago. And it refers to the fact that the availability of good medical care tends to vary inversely with the need for it in the population served. But Tudor Hart also said, which is really critical for us to remember, that this operates more completely where medical care is most exposed to market forces and less so where such exposure is reduced. Now, I don't have time in 20 minutes to go into this, but there is definitely a creeping privatisation of our healthcare services and our systems across Europe and in Ireland that are going to have negative impacts on things like the inverse care law. Next slide, please. So this is the concept of the deep end. These are GPs, some at the shallow end, which is meant to be the most affluent areas, and some down in the deep end. It's not to say that GPs working in more settled or affluent areas don't find things difficult. So they could be, struggling a little bit. But if you're down in the deep end where there's far higher need, you're struggling to keep your head above water. And this really refers both to the people living in those communities, but also to the healthcare workers trying to provide care for them. Next slide, please. So this is data from Scotland, and it's the whole of the Scottish population. And basically, it divides the population into deciles. Number 1 are the most affluent and number 10 are the most deprived. The blue and the red lines are mortality and multimorbidity, essentially. And as you'd expect, they're much higher in the most deprived areas. The black line is the funding going into general practices across these different areas, which essentially stays flat, and there's no significant difference in those trends across the different deciles. And then if you look at the green line, it's the consultations per 1,000 patients registered. So in the most deprived areas, there's 20% more consultations for patients registered than in the most affluent. And the only way GPs can be doing that work is if they work longer hours or do shorter consultations, which will reduce their quality of the consultation. So, that's a very significant difference. And this is in a system that already has some deprivation weighted capitation payment. Next slide, please. Interestingly, that data came out after the swimming pool image was first designed in Scotland. And if you turn it upside down, you get the same idea. Next slide, please. So the deep end idea began in Scotland about 15 years ago, and there's now about, I think there's about 13 or 14 deep end GP groups internationally. And the particular challenges working in these areas for and living in them, for the patients, it's about the kind of often very hidden impact of poverty, the day-to-day struggles trying to make ends meet, which often means that you will not prioritise your healthcare. There's also much higher patient complexity, both because of more complex mixtures of physical and mental health conditions, but also psychosocial issues like addiction. There are intergenerational effects on health that we're now really aware of. Lots of biological research now looking at inflammatory markers and epigenetics in early life and the impact that they have. But also just in terms of the lives lived, there's a huge amount of instability and movement, changes in contact addresses, making it like, so people who are getting all these validation letters from the hospital, they often go to an address that they lived in before, and then they're just turned off a waiting list. The other thing that's really frustrating for a lot of deep end GPs is that if you get a vulnerable child moved to your practice area, there's no central way of finding out what their vaccination history is. You actually have to go back to all of the areas they've lived in and try and find that out. So there's things that are really frustrating in our system that could be addressed. And in terms of the health system, so we've already mentioned the 20 to 40% higher consultation rates, depending on where you are. And we know that in the north inner city of Dublin, which is a very disadvantaged community, GPs have much larger list sizes, so about 2,500 compared to the national average of 1,600. So unsurprisingly, there tends to be higher GP turnover and other primary care staff in those areas because the work can be quite challenging. And then also from Scotland recently, from the Deep End group, there is this concept of missingness. And it's a really interesting idea that our system is kind of nearly functions because we have a lot of people who don't attend appointments and a lot of what we call do not attend or DNA rates. And that actually, they've now shown that if you have DNA in your medical record, you've actually got a higher mortality rate in the subsequent year. So instead of it being seen as that, well, at least we can catch up on our clinic times, it should be a red flag for higher health risk. And particularly for children. And I know pediatricians have told me they're really frustrated. Their electronic health record will not let them write anything other than DNA. And for a child, the idea that they have agency to miss an appointment is ridiculous. And it should be recorded as was not brought. And again, it should be a red flag. Potentially, now sometimes children are not brought because the problem has gone away. But very often for vulnerable children, it's because their carers have not been able to get them to the appointment that they need to go to. So next slide, please. And this is just an example of the challenges, particularly facing children around mental health, which we really are having an absolute crisis in mental health and disability services in Ireland. You can see the map there is one of the Hubble Index maps, and the blue are the affluent areas and the orange and dark orange are the disadvantaged and very disadvantaged areas. And you can see really clear kind of population dispersal around Dublin, and none of those areas won't surprise you. But we know from Irish data that 1 in 3 children will experience mental health difficulty now by the age of 13. But we also know that there's a 4.5-fold difference in severe mental health problems in children living in the most disadvantaged communities compared to the most affluent. And that's very likely to play out into the milder mental health issues that tend to be dealt with by psychology rather than by CAMHS. But we know that in all of those dark orange areas, the waiting lists are now at around 3 to 4 years for primary care psychology. And in fact, the waiting lists in the disadvantaged areas are longer because there's no private safety net as exists in the more affluent areas. So most parents will do anything they can and spend anything they can if their child is in distress, and they will pay to see somebody in the private sector. That applies particularly for disability assessments, but also for mental health issues. And therefore, the waiting list for the public patients in those areas becomes lower. In Ireland, we also have a huge reliance on non-governmental organisations or charities to deliver a lot of these services. And in many areas, in Mulhuddart in northwest Dublin, the lists are actually closed to GPs for many of the services that NGOs offer, like Jigsaw or Family Resource Centres, and they're only taking cases from TUSLA. So we really have a crisis in our care delivery. But the one group that these children are keeping coming back to all the time is actually their GP. And next slide, please. But this is a really challenging. This is a diagram that was drawn up by one of the deep end GPs, actually in Mulhutter, Dr. Adele McGinnity. And this is what it feels like to be a GP or maybe a public health nurse, and a parent presents to you with a child in distress. You have this huge range of statutory and non-statutory services. Some are closed, some are open. Most are bouncing referrals back to you. We're all having patients now who are aging out of assessment services. So, and really the adult sector has virtually, hardly anything in terms of disability and mental health crossover services. So next slide, please. This is actually data from England, and it's just, I use it, and some of you may be familiar with it because I think it was published about a year ago or maybe 2 years ago now. And what it's showing us are integrated care areas in England, in NHS England. And they looked at the areas based on the makeup of the population of the areas. And the dark red are the most deprived and the dark blue are the most affluent. So up at the top, you've got Birmingham and Solihull. And in that integrated care area, more than 50% of the population live in the most disadvantaged communities. And down in Surrey, it's less than about 2% are in the most disadvantaged groups, and more than 50% are in the most affluent. Now, historically, in most countries, including Ireland, we have tended to introduce services into these areas as if they were the same areas. Sometimes we might vary it based on age, but we rarely base it on need, which is, and on disadvantage. And we've done that in Ireland as well with our integrated care areas. We have not provided any additional resource that's based on disadvantage in the populations. So next slide, please. This is just some data that we're looking at with the Health Intelligence Unit in the HSE around trying to map who are the GPs working in the most disadvantaged communities in Ireland. And they've divided the medical card patients into 5 groups. So the most deprived group are there, and it's a very unfortunate term, but they call them bucket 1. So it's HP1 is that red group. So what we're interested in are the GPs who are working with those patients. So next slide, please. You can see that there's quite a distribution across GPs, as you'd expect. Nearly every single GP will have some patients who are disadvantaged, but it's when you get into what's called blanket deprivation, if most of your patients are in that category, it becomes really overwhelming and very difficult to provide care. And we know that GPs who have a GMS contract are called contract holders. It's not very kind of human, but there's 95 contract holders who have over 200 patients in HP1, and they represent about 4% of all contract holders. So they really are the GPs at the deep end. Next slide, please. So that leads me on to think a little bit about advocacy. So Deep End Ireland formed in 2012 and began with GPs just wanting to meet to share their experiences to see if they could identify any efficiencies across their practices. And then we became aware of this Deep End group in Scotland and joined up with them. And one of the GPs said it was like she felt like a patient who had found a patient support group. There is something that is different about working in these areas, and it is less of a concern to the majority groups and to unions and to the health system, even though these are often the highest need people. So we linked with the Deep End group in Scotland, and we have been working for well over 10 years now trying to formally identify the Deep End Ireland GPs, and we're getting very close now thanks to the support of the HSE and the Health Intelligence Unit. And over the years we've had a number of reports. We have a website which you can find, deepend.ie, that has these reports on it. We've looked at inverse care laws, link workers providing social prescribing, and we've had a lot of focus on health inequalities in children. We've also met multiple politicians and made submissions to Sláinte Care, to the CAMS inquiries and reviews, mental health submissions, and then more recently to the strategic review of general practice. And we continue to have international links. So next slide, please. So when we go in to meet all of these policymakers and politicians, This is a diagram again done up by Adele, trying to explain the inverse care law, which is pretty explanatory. You've got in your average area, not your most affluent area, you might have one GP or one public health nurse for every 3 patients. In a disadvantaged area, because your list size is higher, you've actually got more patients, but they're also sicker. So next slide, please. When we meet with them, we present data, that a lot of the data that I've already presented today about multimorbidity developing earlier. We show them those Pubble index maps around cancer presentations and higher mortality, depending on what area you live in. And then even if people don't really care about differences in health outcomes, it actually has an impact on everybody, because the 10% of people who have 4 or more conditions account for 34% of emergency admissions and 47% of preventable admissions. So they are actually causing a lot of work in our system, and a lot of this is preventable work. And of course, it would be really improving their own health outcomes as well. So next slide, please. What we've learned over the years is that you can present data, but that stories are also really powerful. And this is an anonymized story of one of our patients, 53-year-old woman. She's got chronic lung disease. She's got diabetes, depression, and severe eczema. She's come in to see the GP because her 14-year-old son has behavioral problems. He's about to be expelled from school. He's still smoking. Her diabetes is not well controlled. She's got a chest infection and she's got a flare-up of her eczema because of all the stress that she's under. And this consultation is not going to take 15 minutes, which is the average GP consultation. She's very, very distressed about her son's problems. And at the end of a long consultation, they realise that actually the GP has got an alert that her cervical smear is overdue, and they're really, the patient does not feel able for it, and the GP doesn't either, and there's no time. So this is one of the reasons why there's going to be a difference in cervical cancer screening uptake in the most disadvantaged areas, and then higher rates of cancer in these areas. So next slide, please. And this is where I would advocate for the exceptional potential of general practice, that we are there. We're the first point of call for these patients, that we can manage. We're trained to manage complexity. We've got continuity of care in our relationships and our management of patients, and information about all the services they're attending. But we need to be able to be resourced to do it well and to do it properly. We know who these families are in our communities that are in particular difficulty, and we tend to be a trusted location that's easy to access. And for example, we often see many of these people in pregnancy, which is a real opportunity for us to engage with these families if there was some resource to do that. Next slide, please. I came across this recently, and it's from the NHS, but it's very relevant. Very often when we talk to people about general practice, because we're a little bit outside of the normal HSE systems, we're contracting into them as independent contractors rather than HSE employees. A lot of people don't understand what we do. It's a strange mixture of hearing ads on the radio, which is basically, if you have any problem under the sun, go and see your GP. And yet people thinking that we don't really do very much, that we fix simple stuff and we refer everything else. And in the reality is of our work is that we refer a small minority of the patients we see, that we do complex holding work with the occasional quick fix and referral. So next slide, please. But it isn't just about general practice, it's also about a health systems approach. And there's some really good work looking at transforming health systems to reduce health inequalities by John Ford, who's both a GP and a public health doctor in England. And he's done various reviews, and he talks about the importance of framing the problem for people who work in the health service. That NHS staff, so Irish healthcare staff, are much more likely to engage if data on inequalities is framed around their area of practice rather than things that are more obscure, like life expectancy. So if you're working in chronic disease management, you need to be thinking about what's the data on health inequalities in chronic disease management, for example. In Ireland, we're slightly mid-Atlantic, and we still have a bit of a charitable approach rather than a rights-based approach to addressing health inequities. And there's this idea of the deserving poor, but there's also a tendency for people to blame people and say, well, if only they didn't smoke, or if only they had different behaviours. But many of the behaviours are a response to lives that are lived very stressfully. And whatever our understanding of it, the fundamental issue and the fundamental need is for a redistribution of resources, funding, workforce, services and power. Next slide, please. So I'll finish up with just maybe some considerations of some potential solutions. In Scotland, they've introduced a statutory duty called the Fairer Scotland Duty that places a legal responsibility on Scottish public bodies to actively consider how they can reduce inequalities of outcome caused by socioeconomic disadvantage when making strategic decisions. So we could do that in Ireland. We have a DESH school model in education. We could apply that to primary care as well. And we really need to have intersectional solutions around housing and targeted benefits for the most vulnerable groups. We need evidence-based, cost-effective interventions, and we have ideas, for example, the Care Plus trial in Scotland, which identified an intervention targeting practices and patients in the most disadvantaged communities it had a cost of £12,000 per QALY, which is well below the willingness to pay threshold of the NHS, but it's not regarded in the same way as a drug would be regarded. And then importantly, we need to learn from each other to build capacity. And I would like to acknowledge that Deep End Ireland is really in a radically different place in the last year, because the Taoiseach's office and the Minister for Health have given us some core funding, which has enabled us to have an academic lead who's Dr. Patrick O'Donnell from the University of Limerick, and a GP lead who's Dr. Breed Shanahan in Summerhill in Dublin 1. And that is allowing us to do way more than we were able to do before. And what's really critical for us to remember is that the lack of early year supports and addressing these inequalities costs England £16 billion per year, and it's almost certainly likely to be in proportionately the same in Ireland. So next slide, please. So to conclude, the fundamental issue is resources. We definitely need allocation based on need, and I know that's within the Sláinte Care framework, but it needs to be really focused on and addressed. We need to target to ensure benefit, harness the potential of general practice, and of course we really need data to support policy and planning. And if I had one thing on a wish list, I would ask for a national health and equity strategy along like the likes of the Women's Health Strategy, because it allows for intergovernmental department working, and that it prioritizes an issue. And this is something that I really believe needs to be prioritized. So thank you very much. I believe we'll have questions at the end.
It's fantastic, Susan. Sorry, I was so busy taking notes. I was late coming on. So that was really good presentation. Thanks a million. And yeah, we'll definitely come to questions towards the end of this session. But for now, we're going to move to our second speaker. So we're going to hear from Dr. Sheelah Connolly. So Sheelah is a Senior Research Officer in the Social Research Division and Joint Research Area Coordinator for Health and Quality of Life Research at the ESRI. She's also an Adjunct Associate Professor at the Department of Economics at Trinity College, and she's a member of the Health Research Consent and Declaration Committee. Since joining the ESRI in 2014, much of Dr. Connolly's research has addressed issues of healthcare financing and access in the Irish context. Sheelah currently manages the Department of Health ESRI Research Programme on Healthcare Reform, as well as working on a range of other projects and programmes. And today Sheelah is going to talk to us about unequal chances and inequalities in mortality in Ireland. So Sheelah, thank you very much.
Thanks, Ronan. I'll just share my presentation. Okay, so as Ronan said, so I suppose just to thank Ronan and Jan and Brian for the invitation to present today. I'm going to present some work that myself and colleagues did in the ESRI a couple of years ago. So some of the data is kind of relating to the period before COVID, and that just reflected the time that this was worked on and data availability. So the focus is on, I suppose, life expectancy and mortality, and these are kind of key indicators of population health and social progress. And generally what happens is that as countries become more affluent and they develop socially, we see improvements in life expectancy. But also what happens is that these improvements aren't shared equally across different groups. Some groups do better, some groups do worse. And we would assume that would be a major policy concern. Such inequalities in mortality and in other indicators, they're potentially avoidable, and they're, most people would regard them as unfair. And I suppose while I have said there that this is a major policy concern, it probably is not an area that has received enough attention, I think, in Ireland. And I'll come back to this at the end of the presentation. But it's a lot of our conversations, I suppose, on health very much focus on the health system and very much focus on the hospital side of the health system. And while we have had initiatives like Healthy Ireland in more recent years, we really probably need to have more of a conversation and more of an emphasis on actually health and what we need to do earlier on to improve health and to reduce inequalities. And just to acknowledge that this work was funded from the Institute of Public Health, who have had, I suppose, an interest in inequalities, both socioeconomic and other indicators for a number of years. So they funded this work for us. So I suppose today I'm going to focus on time trends in mortality just from the year 2000. So very recent past, really, I suppose, that many of us would have lived through and experienced. And then I'm just going to look at the socioeconomic inequalities in both adult and perinatal mortality. And when I get to perinatal mortality, I'll explain why we focus on that as well. So the work that I'm presenting today, there is a report and a paper freely available on the ESRI website. So if you are interested in any particular dimensions of what we've done, be it the methodology or the findings, there's much more detail there in the report. And I'll just give you, I suppose, a flavour today in terms of what we actually did and looked at. So I suppose before we got into the kind of the meat of the presentation, I just wanted to say something about socioeconomic status more generally, because it's a term that is used and that we use, quite a lot. And I think we probably have some idea about what we mean by socioeconomic status when we use that term. This is one definition from the literature. It's a person's position in the social stratification system. Okay, so that kind of makes sense. That rings true, I suppose. But how do we actually measure it and how do we identify it? And in the health inequalities literature, at least, there's been a number of different ways that I suppose groups have been established or people have been allocated depending on a range of indicators. So some literature will use education, sometimes it's income, sometimes it's wealth. A lot of the dimensions are around occupation, it's social class, it could be housing. Arises the question, well, should that be the individual that you're looking at, or should we be concerned about these indicators at the household level? And some of them make sense at the household level, such as income, but maybe something like education makes less sense at the household level. Area level factors are important. And how do we measure, how do we identify a deprived area? And again, we might look at an area and have a sense, okay, well, that's deprived, this is less deprived, but how do we actually quantify that? And again, there's been various measures or various ways that has been done. So looking at the percentage of the population in an area that are unemployed, or there's been composite indicators which have tried to kind of bring together a number of different area-based indicators. And I suppose ideally when we're doing this sort of work, you would kind of have some sort of idea that the mechanism which is leading to the inequality that you're looking at, maybe it's education, maybe it's an income effect, maybe it's access to healthcare services, and then you would use that indicator. But what we find in Ireland and in other countries as well is that often there's such a lack of data that you don't have any choice about what indicator you use because there is only one indicator available to you. So it kind of limits what we can do, I suppose, to some extent in the Irish context. So looking at the adult mortality then, start by saying that what we did was quite crude. It's a quite crude analysis, I guess. But we knew this is what we would have to do. This is the way we would approach the question, just given data availability in Ireland at the time of doing the analysis. So what we were interested in was mortality. So there is a data set on vital statistics, and this records all deaths in Ireland. And there's information on the person that died, their sex, their age. Important for this sort of research, there's information on their last known occupation, and there's information on cause of death. And we also used information from the census of the population. So what we did is, in I suppose, a kind of a quite crude manners, we look at, for example, the number of cancer-related deaths for males aged 55 to 64, whose occupation was regarded as higher professional. We look at the men in the census in that year, aged 55 to 64, higher professional. And we can use that information to create an SMR, a standardized mortality rate, which gives us an indication of the death rate for that group. So I won't go into it here. We can talk about it more in the question time if there's interest. But you can imagine that this is probably not the way you would really want to be looking at inequalities in mortality. So while we expected, that was what we were going to do, when we got into the meat of this, actually, the data environment was poorer than we initially expected. So the two different sources, the vital statistics data and the census of population data, actually the way they measure socioeconomic group differs across the two of them. So they both use an occupation-based measure where they allocate individuals to different groups. But the two indicators, the two groups were different. So we had, I suppose, quite a length of time to try and bring the groups together, to try and allocate people from one group to the other group to ensure that we had some sort of consistency across the two groups. So again, it does introduce, I suppose, a margin of error. Even within the vital statistics data, the way that socioeconomic group was classified changed over time. So I think it changed around 2012, 2013. So that prevented us doing some sort of longitudinal analysis because the two groups, were different over time. Another issue as well when we're doing this work is that there should be micro data files available from the CSO. But when we were doing this analysis, they weren't available to the research team. But while the CSO did provide us with aggregates of data, so rather than the more disaggregated data, it really limited the type of work that we could do, in particular around cause of death, which was a particular interest, I suppose, at the outset. So I guess a kind of a good news story to start off. And so this is the period 2000 to 2019 in Ireland. And what we're seeing is a decrease in the adult standardized mortality rate by sex. So for males, I think it has decreased by about 40%. And for females, the decrease has been something slightly less, maybe about 33, 34%. So that inequality between males and females has actually narrowed a little bit over time in terms of the standardized mortality rate. So that's I suppose the good news story. So, but I suppose our particular interest today was, well, what's actually happening to the distribution of these deaths. So another change is in the kind of the major causes of death between this kind of 2000 to 2018. So just a relatively recent 18-year period. What we're seeing is that causes of death attributable to circulatory diseases such as heart disease and stroke, they're a lesser proportion of the overall deaths. So from 41% around 2000 to 29% in 2018. So it could be that people who have one of these conditions in the past, they were more likely to die, but now because of better treatment and maybe earlier intervention, they're living a longer life. Cancer as a proportion of deaths has increased from 25% in 2000 up to about 30% in 2018. And again, we know that age is a significant risk factor for cancer. So it could be people that previously or that still have circulatory diseases. They're not actually dying from it anymore, but because they're older and age is a risk factor for cancer, they're more likely to die from a cancer-related death. So we're getting to a situation, I suppose, of multimorbidity. Respiratory as a cause of death in terms of the proportion of deaths has decreased a little bit over this period as well. And Ireland, I did some work on this numerous, I think it was about the year 2000 to 1999, 2000, looking at causes of death and comparing them, relatively to other countries. And in Ireland, we do seem to have a particular issue with higher rates of respiratory related deaths. I think the majority of deaths there in the respiratory section are probably pneumonia, maybe about 40%. And I suppose where we really fell down with the data was this other group. So it comprised 18% of deaths in 2000, but a much larger share of 28% in 2018. We can't say very much about what is going on there because it includes so many different types of deaths. So it's accidents, it's suicides, it's neurological related deaths, it's infant mortality. But I suppose just we really, we would need better information to try and untangle and see what's going on within that area when it is a growing, I suppose, proportion of our deaths over time. Turning then to the kind of the socioeconomic division. So what you'll see here is we've got 5 different socioeconomic groups. So from the employers and managers, higher and lower professionals, and the non-manual group. And in this analysis, we didn't find a huge amount of difference in standardized mortality rates for those 3 groups. So it's up and down in the different years a little, but no significant differences between those 3 groups. Where the big differences did come in, I suppose, is in the two latter groups. So the yellow bars, which is the manual workers largely, and then the red group, and that's a bit of a catch-all group, I suppose. It's generally the most deprived, and it includes people whose occupation, just wasn't recorded on their death certificate at all, or it was recorded and it wasn't possible to assign them to one of these particular groups. But generally that group we kind of regard as a residual or an unknown group, and it's those, I suppose, who are less attached to the labor market. They may have had long-term unemployed, and they're really, I suppose, the most disadvantaged. So what we're seeing with the standardized mortality rates is that this is a very significant socioeconomic gradient, and one that over this relatively short period, we couldn't look at it over a longer period just because of the way that the socioeconomic groups were devised, but no real sign, I suppose, of a reduction in socioeconomic inequalities over that period. This is it looking at by cause of death then, and to some extent it is a similar picture to the previous slide. The inequalities are there for each of the 4 causes of death that we looked at. For something like cancer, you have a slightly more stepwise group, which I think is kind of bringing back to Susan's point that it's not just the most disadvantaged, but sometimes you have higher rates of morbidity and mortality that as you get more deprived, as the level of deprivation increases, even though people aren't very deprived, the rates of ill health and mortality can increase. So we're seeing this again, that the yellow group, the manual workers, and this more unknown, or this group that have less attachment to the labour market, they have higher levels of mortality from each of the 4 underlying causes of death that we could examine. It's kind of hard to see it in this figure, but actually the inequalities are highest for respiratory causes of death, where for the most disadvantaged, that kind of red group, it's double that for the employers and managers. And next to respiratory, the level of inequalities, or the extent of absolute inequalities, was higher for all other causes. So that kind of really unknown group that includes so many different potential causes of death. Notwithstanding that, there are significant inequalities for both cancer and circularity-related mortality as well. Turning to perinatal mortality. So perinatal mortality is it's a stillbirth or the death of a child within the first 7 days of life. And again, this is kind of going back to Susan's point about, the impact of early life on a person's circumstances throughout the life course. And even more stark than that, the circumstances of the mother or the father can actually determine, whether the child actually survives beyond, a very short period. We included this because there's actually a good data set in the Irish context. So it was something that we could look at. We were interested in looking at children's mortality as well, but I suppose in a positive note, the number of deaths of children is relatively low. So it's not very easy to get at that, by dividing it into socioeconomic groups, because your numbers, become quite small. So here we looked at the number of singleton perinatal deaths per 1,000 births by mother's socioeconomic group. We focus in on singleton births because we've had, I suppose, in the last number of years, an increase in multiple births, some of which has been driven by an increased number of twins and triplets, which is kind of driven by an increase in fertility treatments. So if we looked at, including multiple births within this statistic, you get not very different results, but there's more to unpick, I suppose. So we looked at this as just the singleton birth. So there was only one birth. Again, it was based on occupation, but it was based on the occupation of the mother. As a sensitivity analysis, we looked at the occupation of the father as well, but didn't come up with very much differences from the mother's the results. So again, a good news story in terms of mortality. So we're seeing a decrease in stillbirths over this relatively recent period. So from about a high of 8.3 in 2000 to about 5.4 in 2019. So I suppose, again, the concern is today, well, has this decrease been shared equally across all groups? And what we're seeing is, well, first of all, there are, again, significant inequalities across the socioeconomic groups in the likelihood of experience of perinatal death. So this is 4 time periods over time. A bit more diversity, I suppose, in the kind of the more affluent groups, I suppose. But again, there's 2 groups that are coming out as having significantly higher rates of perinatal mortality relative to more affluent groups. And they're mothers who were unemployed and mothers who were involved in home duties, who are not working formally outside of the home. And I suppose while we weren't surprised about the unemployed mothers, we were a little bit more surprised about the finding about the home duties and trying to unmask what was going on there. And if you look at this table, which comes from the subsequent paper rather than the actual report, what this shows us is, well, how does the relative rate or the relative likelihood of a perinatal mortality differ across these groups? And for the unemployed mothers for 2 time periods, so the earlier time period and the later time period, what you're seeing is the kind of the relative risk, the likelihood, the increased likelihood of having a perinatal mortality for the unemployed mothers, it decreased slightly between the 2 time periods. But for those that are involved in home duties, the elevated risk actually increased over the 2 time periods. Now, we don't know exactly what's going on there. We know that if you compare the 2 time periods, and there was the Celtic Tiger years and then the crash in the 2004-2011 period, 2012-2019, potentially a bit more of a stable. It could be a composition effect that those that were involved in home duties differs to the time. But I suppose it is a concern, and it would be useful, I suppose, to be able to dig down into that, to try and to get more information on what's happening in that context. So I suppose by way of summary then, we have got evidence of significant socioeconomic inequalities in mortality in Ireland. The data is not great, and it doesn't really allow us at this sort of kind of national, at this population level, to dig into some of the causes on inequalities. We looked at, and I presented on socioeconomic inequalities here today, but there are a range of other dimensions as well. And one of the things that we looked at or tried to look at in the report is ethnicity. So this can be important in its own right, I suppose, especially as Ireland's population becomes more diverse, but also because you can have overlap and interactions between ethnicity and socioeconomic status. So we did find, significant inequalities by mother's country of birth, and some of that was explained by socioeconomic status. So it's really digging down into those is useful. I think more focus is required on the social determinants of health, and this is raised by Susan as well. But it's complex, and it needs multi-sectorial and multi-departmental, I suppose, input. Is it about poverty? Is it about housing conditions or the local and built environment? And how, I suppose, can we work together, and how can different groups and different departments work together to try and improve health for everybody, and in particular for those that are most disadvantaged? Also, I suppose there is a need to improve the data, even for work like this at the population level. In other countries, and also in the past in Ireland, we have moved to a situation where after the census of the population, people were followed up for a number of years. So it's possible to link their census return to their death records. And it gives us a much, I suppose, more a variety and a much more richer data set. But even as a much shorter term, I suppose something that we could do is to look at harmonizing indicators of socioeconomic status and ethnicity across administrative data sets, because at the moment, different data sets are using different indicators, and even with indicators that are potentially trying to capture the same thing, the way they're classified has differed over time and across sources. So it makes it very difficult to get a good idea, I suppose, of what's actually happening over time in this space. So I will stop sharing there.
fantastic, Sheelah. Thanks very much for that. And we'll come to you for questions a little later. And so now we are going to hear finally today from Helen Gaynor. So Helen is Head of Community Support Services at the Irish Heart Foundation and has over 25 years experience working in the non-profit and disability sector. Prior to joining the Irish Heart Foundation, Helen was Rehabilitation Service Coordinator at Headway Ireland. And Helen's talk today is entitled Unveiling Inequality and Access to Self-Management Support and Information for Patients with Cardiovascular Disease in Ireland. So Helen, thank you very much.
You're very welcome, Ronan. Thank you so much for inviting me on this webinar. I'm honoured to be here. So just a quick word about the Irish Heart Foundation and what we do. So we are a community of people who fight to protect the cardiovascular health of everyone in Ireland. And our mission is to eliminate preventable death and disability from heart disease and stroke, and also to support and care for those living with these life-changing conditions. A big part of our work is campaigning and advocating for policies to support people to live healthier lives. So just a quick note on the prevalence of cardiovascular disease. So good news is CHD mortality rates in Ireland have halved since the mid-1980s. And there's been a reduction in stroke deaths from 19% in 2010 when the National Stroke Strategy began to 11% in 2020. However, coronary artery disease is still the leading global cause of death. It accounts for 13% of deaths globally in 2021. And then the Burden of Stroke report from the King's College in London has predicted a 58% increase in stroke cases by the year 2035. Also, since 1975, there's been a tenfold increase in childhood obesity. So really, we know people are surviving cardiovascular events, but more and more people are living longer with them. And that is why accessing self-management support and the information, the right information at the right time, is critically important. However, this is not easy, and despite being a low-hanging fruit in many ways, there is ongoing systematic barriers similar to what the previous speakers have discussed in accessing these self-management supports. So essentially, the benefits of accessing self-management support really are an absolute no-brainer. And the definition is the daily actions and decisions individuals make to manage their heart health effectively, which is the HSE definition for self-management for cardiovascular health. And the reasons why it's so powerful: it can significantly improve health outcomes. It can reduce hospital admissions by 30%, reducing mortality rates, improving quality of life, and then improving self-efficacy. So research has shown that self-management done right works. However, there's a number of many inequalities in accessing self-management. And just listening to the previous speakers, really a lot of the inequalities in accessing self-management are so similar to the inequalities people face in living and really the inequalities that we face in society as well. So today, in the interest of time, I'm just going to focus on social inequalities, health literacy, psychosocial inequalities, so barriers to accessing social and peer networks, gender, and I'm going to just focus in on heart failure, which is a very complex condition that we support in the Irish Heart Foundation. So just in relation to social inequalities in relation to cardiovascular health, so evidence for policies to prevent the chronic conditions research group examined the prevalence of chronic conditions by level of deprivation using data from the Healthy Ireland survey in 2018. And they found the prevalence of coronary or heart disease among those categorised as disadvantaged or very disadvantaged or extremely disadvantaged was more than twice as high than among affluent individuals. And standardised mortality rates in adults 2014 to 2018 were twice as high among manual skilled to agricultural workers than employers and managers. So again, this has been mentioned, the social determinants of health and the biology of adversity. And really, in relation to this, it's knowing that these are the circumstances as defined by the World Health Organization as the circumstances in which people are born, grow, live, work, and age, and then the systems put in place to deal with illness. So we know that there is a significant connection between the social detriments of health, the biology of adversity, which is even before people are born, they're already facing adversity, and the impact that has on people's outcomes with health. So just touching now on health literacy. So the World Health Organization refers to it broadly as the ability of individuals to gain access to understand and use information in ways which promotes and maintains good health for themselves, their families, and their communities. And it really does expand beyond this definition. And really, limited health literacy is more prevalent among racial and ethnic minorities, older adults, individuals with less education, and it's also strongly related to socioeconomic position, English language proficiency, and the development of general literacy as well. So there's a huge connection between health literacy and someone's health outcomes. And then just to illustrate that connection, as you can see, there's also this huge connection between health literacy and self-management. So again, it is that, you know, someone starts off maybe in adverse circumstances, that tends to spill out into their use of health services, their ability to look after themselves, their engagement with health services, and then it translates right across to their quality life, and ultimately the link is there with mortality and healthcare utilisation. I'm going to focus now on a short case study around travellers and a piece of health information that the Irish Heart Foundation designed with travellers to improve their heart health. So, as you know, there is persistent racism and discrimination for this ethnic minority, and they have significant poor outcomes in education, employment, accommodation, and health. And just focusing in on traveller women, so traveller women live on average 11.5 years less than the general population, and the leading cause of deaths in travellers was identified as heart disease, as well as external causes, respiratory diseases and cancers. And then the mortality rate among traveller infants estimated at 14.1% for every 1,000 live births. So a lot of inequality with this ethnic minority. Just going to our focus, the Irish Heart Foundation's approach now to creating health content and our plans really going forward is we are acutely aware now how important it is that any health content is designed with these 4 principles in mind. The need to be user-focused, the need for it to be easy to understand, inclusive and accessible, and evidence-based. So instead of expecting people to improve their literacy levels, we need to make sure that we're designing our information supports and our services to underpin these principles. So going back to the travellers, so we designed a leaflet, it was a co-designed leaflet with women in the travelling community, and it was done as part of the Work for Her Heart Matters campaign, which was running a couple of months ago. And it took a while to co-create, but essentially what was created was a resource for traveller women that really focus around those principles of health literacy. So less text, more real world imagery, and importantly, we used the use of their language and photos from the travellers community. So just touching here then on the barriers for women in terms of self-management for cardiovascular disease. So we know there's ample research that has highlighted women have unique risk factors in relation to cardiovascular disease, which I won't go into in this presentation, but just when it comes to diagnosis and then self-management, again, women are facing a lot of unique self-management issues. So the usual issues, there's you know, their roles as maybe carers, maybe they're looking after their kids, disadvantaged backgrounds, environmental risk factors as well, and then relationships and key psychosocial risk factors can all impact on the outcomes for a woman in terms of understanding and benefiting from managing her health after a cardiovascular event. So I'm just going to touch on social isolation. So in our service, we notice that the people who use our patient support services would really describe to us just feeling very alone in living with their diagnosis and managing their diagnosis. And we can also see through the use of our supports that getting support around their social needs really makes a difference. So in relation to data, you know, there is good research to show that there is this connection between social isolation and poorer outcomes with cardiovascular disease. Certainly one is that, you know, women tend to, especially people maybe who are socially isolated, they might have less interactions with people. Certainly they would have higher rates of depression and anxiety, and they also would maybe be lacking somebody to look out for them. And we know certainly with a lot of our members who have survived a stroke or a heart event, you know, they depend a lot on family to support them in their self-management. So if someone is living alone or socially isolated, that can really have an impact on their ability to self-manage. And there was research done, Tilda data, it was done on 4,888 adults who were over 50, and it measured their resting heart rate. And these were adults who were socially deprived, but also were actually very socially isolated. And the data showed that the people who were living alone or isolated, there was a higher incidence of, they had a higher resting heart rate, which is a significant risk factor for cardiovascular disease. I'm going to touch now on heart failure because it is a very complex condition, as the medics on this webinar today, no doubt is very aware of. In terms of what we've noticed in the Irish Heart Foundation is, you know, it's a condition that tends to have very poor outcomes, but self-management and self-care is extremely important for people who are living with heart failure. We did a recent survey in 2022 on people living with heart failure in the community. And from this research, 74% had no or inadequate psychological supports. 60% of heart failure patients experience a drop in income and an increase in living expenses. 40% of working age heart failure patients had no medical card or GP visit card. And there's 96,000 people in Ireland living with heart failure, yet there's no register. So there's a huge need for support for people living with heart failure, but also for people who are trying to get on with their lives. The psychological barriers are huge. And one massive statistic that really, I suppose, you know, made us think a lot was the high incidence of people living with heart failure who did not have access to psychological support. So it is definitely a barrier to people being able to live well. It's a condition that has very high rates of depression and anxiety, and psychological support, psychosocial support is extremely needed. Also, there is still no national cardiovascular strategy, which of course impacts the outcomes for people as well. So to just come to the end of the conversation, how to address these inequalities, I don't have the answers. There is some interesting research gaps, I think, that need to be looked at. So definitely the role of health literacy in cardiovascular disease. So it would be great to see more research done, especially on those vulnerable groups in society. Certainly a populational health approach is, research has shown, is the way to approach this. Patient-centered care, integrated care, community-focused interventions, and then reframing lifestyle. I think this came up in an earlier presentation. So instead of shifting the blame to the individual, addressing the system level changes needed. So I just want to discuss the heart and stroke support pathway that we have for patients living with cardiovascular disease in the Irish Heart Foundation. And we designed this pathway to try and give people the information and the support that they need after they've been diagnosed with a cardiovascular event. And we very much tried to design the service to meet those needs of people, and it's an ongoing design process. So the way it works is we will receive a referral, and referrals can come in self-referrals, GP referrals, or heart failure clinics or stroke unit referrals. And then when people come into the service, they get an holistic assessment of need, and what we focus on in that assessment of need is not just the needs that arise around their diagnosis, it's also the needs that they have in their lives. So we will ask them, what's the most important thing to you at this very point in time? And a lot of the time, it actually is not the condition or the diagnosis. It is something like their children, or getting back to work, or multiple different issues. So it's really important to get that full picture of what's going on for someone to be able to support them properly. We then offer phone support, which we find is an easy way to access people maybe who have difficulties with maybe transport or high levels of fatigue, and very much focusing on those issues that come up for people after stroke. A huge part of what we do is signposting into other services, as well as parallel services that we provide. So I mentioned the need for psychological support services for people living with cardiovascular disease. So what we offer in the Irish Heart Foundation is counselling, and we've a network of counsellors all over the countries that we can refer people into. We also have a nurse line that people can ring with any questions or queries. And we also support carers and offer them counselling as well as support on the calls as well. So there's other ongoing options as well. We can offer ongoing face-to-face groups. So we have a network of stroke support groups around the country, and we've just started up heart peer support groups in 2024, which we hope to grow next year as well. There's also a younger stroke survivor network, and we will also offer short-term courses in various different interventions like mindfulness, fatigue management, and getting back to work. So another program that we're running in the Irish Heart Foundation is it's the high risk prevention program. And just a bit of background on this. So this is based on the high rates of CVD, but also the fact that 80% of cardiovascular disease cases are preventable. This program is a behavior change program, and its aim is to reduce the risk of CVD among individuals identified at high risk. So the staff would work with the HSC's chronic disease management program to identify these individuals in GP practices. And the way it works is that people are educated around the risk associated with cardiovascular disease and the importance of lifestyle changes. But it's very much an approach of motivational interviewing. It's a very person-centered approach, and it has had great results. So here's just a snapshot. So as you can see, people's well-being increased, they reduced their sedentary behavior, exercise increased, and there was also good outcomes with smoking rates. So it's an example of a program that is tailored to the needs of the individual, and again shows how that patient-centered care makes all the difference. So just coming to the final slide, I guess we've looked at a number of different things. And, we really, I suppose, need to focus on, why are we treating people and sending them back to the same situations, circumstances, and conditions that make them sick? And when we know how important self-management is and how important it is to give people the information that they need at the right time, it's so important to focus on what can we do to change maybe how our services and our interventions are designed and delivered, so that people can access that information and can access what they need to know to continue to live well despite their diagnosis. So I'll finish up there, and thank you so much for listening.
Brilliant, Helen. Thank you very much. And if I can ask Susan and Sheelah to turn on their cameras as well, and now we'll spend some few minutes having Q&A. And just to encourage people, if you do have questions, please pop them in the chat, and we can put them to the speakers. But Susan, I might start off with you in the first instance, if that's okay. I was struck by the slide which showed the difference in disadvantage across the NHS areas in the UK. And you made the point that traditionally we provide resources based on geography rather than on need. And I know in your concluding slides you mentioned DESH as potentially one avenue to kind of do this differently, but I just thought I'd give you the opportunity to talk a bit more about that and maybe like how we might approach this differently in Ireland.
Yeah, well, thank you. I mean, the DESH model is actually a really interesting one. It's not probably funded enough, to really realize its potential. But the principle of it is that we recognize that children in the most disadvantaged communities and, the schools for them need more resources, and you target those resources. And the other thing that's interesting is you don't expect the teachers to build the schools or to provide those additional resources themselves. And so what's really needed in primary care, in general practice particularly, is we have a massive issue with numbers of GPs, but they won't set up in those areas unless they aren't taking a massive financial hit. One of the problems is they're often in the city centre, even though they're deprived. The buildings are very expensive for a GP to buy to set up in. So it'd be very straightforward for the HSE to build a primary care centre and bring in GPs to work, in those communities. Now, it is a little bit complex in that there needs to be kind of lots of sophisticated kind of mechanisms in place, because you don't want to have a system where a GP can just pile loads of patients onto their list and not provide them with a proper service. But that's a contractual issue that could be monitored. So by and large, what we would be advocating for is that GPs in the most disadvantaged areas would be given infrastructure supports, so that there are premises for them to work in, but also they may have smaller list sizes, and not be financially penalised for doing that. And one way you could do that is you could just simply have some kind of deprivation weighted capitation, so that a patient in the most disadvantaged area gets more resource. At the moment, we give a lot more resource for older people, but Breed Shannon in Summerhill looked at the average age of death in her practice in men, and it's 56. So actually weighting by age is going to disadvantage practices in the most, in the poorest areas, because their patients don't live that long. Now, that's on average. I mean, the other area where this plays out, of course, is in hospitals, because some hospitals serve communities that are much more disadvantaged than others. And again, we don't recognise that in the resources that we provide for them. And it's even just an efficiency issue. Like, we should really be matching resources to the health needs of the populations. And in Ireland, we're really so far away from that, particularly with our mix of public and private. We have all of this, activity that's fee per item in the private system, which, I know the focus today is really on chronic disease management, but that really plays out in that people who are affluent can get multiple fee per item procedures done through health insurance in the private sector. And we have absolutely no idea what's going on. There's no data coming out of those systems. And meanwhile, the people who are high need and cost a lot to the system, they're not going to be in the private sector, because the private sector doesn't really want to manage those kind of patients. So it's the multimorbidity, it's the mixed mental and physical health problems. So we really do need to have, and Sláinte Care does offer pathways to do this well. I guess we need continued political support for it. And there are plans to do this. So it's just a question of whether it will actually push through and happen.
And maybe just a related question then, you touched off it, I think, in your answer there, but in your presentation, obviously you mentioned, the average GP consultation time is 12-15 minutes.
Yeah.
And it's just not long enough for patients with, regardless of deprivation state, it's not long enough for some multiple.
Yeah, with complex needs,
comorbidity, yeah. So is there examples internationally of where of a different model around consultation time that has been adopted that you're aware of?
Well, I mean, that Care Plus study that I mentioned in Scotland, so what they did was they resourced the GPs to have longer consultations with more complex patients. And it's funny, we have the first time that the Irish health system has ever recognised this at all was in 2020, when they introduced a new urban deprivation GP grant. Now, a practice gets about €16,000 a year, and it can do what it feels it needs to do with that. And then it has to tell the HSE what it has done to get the payment. Now, some of the deep end GPs thought this is crazy. They're giving me money to do more, even though I'm already doing more to begin with. It's not really addressing the issue. But what was interesting, we did some research looking at what did GPs do. And many practices use that money to give to an extra GP session to do longer consultations with more complex patients. Some practices got link workers in to do social prescribing, some got counsellors, some got interpreters and translators. It would depend a little bit on the area they were in, but certainly longer consultations would be something, and maybe you book them in the afternoon. Now the challenge is some of these patients may not turn up for these appointments, so you have this balance always of there's a lot of stuff around trauma informed care as well, that you if they just drop in, that you try and see them. But that's going to make everyone else annoyed who's sitting in the waiting room because they've got an appointment. So yeah, but there are certainly ways around it and examples of better practice in doing that.
Okay, brilliant, thanks. And Sheelah, I might come to you next. So I think a key point that you were making in your presentation, and I think we kind of heard it across the three presentations, and pretty much every webinar we do, this comes out in some shape or form, to be honest. But it's the data environment, and that when you went to look at to do this research, that that data environment was poorer than what you would have expected. And I suppose the question is, we tend, or historically we've tended to rely a lot on what international studies are telling us around inequalities and extrapolate that to Ireland. So what can we do here now to improve the data in Ireland so that we can tell the story that's localized to region and to the country?
Yeah, and I suppose it's something that I think that came out across the three presentations. There was some nice evidence and nice data from the Irish setting and some from the UK as well. But I suppose what we don't have is, if you're the new Taoiseach, you decide, you're going to tackle health inequalities. Where's the source? What do you go to? So what we have is ad hoc pieces that are focusing on a particular cause of death or a particular chronic disease or the particular, group. They're generally not longitudinal. We don't have anything that we can use that kind of definitively at the population to compare, I suppose, over time. I mean, one of the kind of something that could be done at a relatively low cost is to start with something like the census of the population. It includes, now it does exclude a very small, I suppose, very disadvantaged group probably, but it probably includes about 99% of the population. If we're put in questions there on chronic disease. So at the moment, there's questions on kind of self-reported, general health status. So something on chronic disease there. Keep it in consistently over the census. We have a good range of socioeconomic indicators. We have good indicators on things like ethnicity. And at least, it's not going to solve all your problems, but it would give you something to benchmark of what's going on in inequalities over time. I suppose what it doesn't get at, and I think was a point that Susan made, it was around health service utilization. And again, there are data sources out there such as HYPE and I suppose, which, for the hospital-based system, but they often lack that dimension on socioeconomic status, that we don't know what somebody's socioeconomic status is. So I suppose as we're moving, increased digitalization, moving towards something like the kind of European health data space, which, it could be a number of years off yet. The likelihood is there will be good health information in there, but, could we push to get some socioeconomic indicators in there as well? Maybe more than one indicator, which would really allow us to look at these issues, both in terms of the impact on health status and on health service utilization, I suppose, over time in some sort of consistent manner would be, not huge undertakings, but maybe just need some thinking at the outset to get these up and running.
Yeah, because I guess a huge part of the story that you need to tell when looking for funding is impact or potential impact, and without the data, it's very difficult to show that, particularly in terms of health service utilization. So
absolutely.
So okay, thanks for that, and I'll come back to you maybe in a moment, Sheelah. But Helen, you obviously had a particular focus on health literacy in your presentation, and just I thought that was a really interesting graphic about how less health literacy can impact right across the spectrum, ultimately ending up in greater morbidity mortality, and health service utilisation.
Absolutely.
I suppose the question is, how do you think we can better address that?
Yeah, it was very interesting actually, just reading about it and seeing how it pretty much starts from birth, and it's all the disadvantages stacked against people from very, very early. So in terms of how to address it, there's certain principles actually which the American Heart Association actually have taken on board, and they're called universal access principles to health literacy. And it's about using plain English. There's a very good method around self-management, is called the teach back method, taking an approach of cultural sensitivity, inclusivity, and then making sure health information is available in a format that people can access and that understand depending on their own situation and background. So it's probably not that we expect people to have to increase their health literacy or improve it. It's that the services and supports change ourselves and our approach to how we organise services to address that need.
Okay, and I guess that comes to a question that I think maybe all of you might want to input on in some shape or form, but like I think another theme that came across the presentations was the need to reframe how we discuss some of these issues, and that, to an extent at least, there's still a blame, even if it's subconscious. There's a tendency to blame some of health outcomes on the individual, as opposed to either the circumstances in which they find themselves or the way in which services and supports in the health system are organised to support them. So I suppose just a general question to all of you as to your thoughts on how we can move forward that reframing, or what can we do to help to reframe that, and both in terms of those making decisions in the health sector, but also maybe amongst the wider population.
I don't mind jumping in first there, Ronan. I mean, I think partly we need more education, both as professionals, but also the population in Ireland. Only 20% of health outcomes are driven by the health services. The rest is all the social determinants of health, your built environment, maybe things like diet and exercise we can have some influence on. But like, if you don't have anywhere to walk, you can't go out walking. If you don't feel safe, all those kind of things. I mean, we had a very interesting experience in Deep End a couple of years ago, well, probably about 7 or 8 years ago. A very well-known TV presenter wanted to do a program on how she'd basically whip all these people into shape. And she came out and she asked, one of our practices gave her access to a family. And she was kind of trudging across the green, carrying their healthy weekly shopping that she had kind of insisted they buy. And like, basically she completely changed her tune by the end of the experience. She just thought, like, I couldn't do, she said I couldn't do this myself. So how I could possibly expect somebody else to do it. It was really eye-opening. But I think we need more understanding of, I mean, it's very, after the whole Trump thing, there's this whole thing going on in the world where we don't really understand each other's perspectives and each other's experiences living life. And having a better understanding would lead to less blaming, I think. And this idea of, oh, well, how can they afford a Sky Sports subscription, and they can't afford their medicines. Like, we just don't understand what it feels like to be living under those kind of pressures. And maybe the Sky Sports is the one thing that you're going to get some pleasure out of. And you don't think, well, if I don't take my blood pressure meds, it doesn't matter if I get a stroke in 10 or 15 years. So I think it's about wider education about people's experiences, but also about the impact that the health service can have, that we need to have a focus on the social determinants. And one of my concerns about social prescribing is that we're seeing it as a bit of a kind of a savior kind of intervention. And there may not be community services to refer people to. There has to be enough resource in the community to support people. Like what Ellen was talking about, that idea of social isolation and lack of connectedness that people have, they really do have profound impacts on people's health. And but programs like XWell, the HSE are funding that in some areas now, really provide an opportunity for both physical activity, but also for social connection. So that's maybe, it's a bit of a long-winded answer, but happy to hand over to the others.
Yeah. I might go next, Ronan, just to answer that, and just to remind everyone, we've patient-focused supports in the Irish Heart Foundation, so feel free to refer on. But I definitely think that that focus from blaming the individual to maybe looking at the system level changes that need to happen. So maybe that term lifestyle, moving away from it, because it tends to kind of frame health and well-being on the individual level. You're effectively blaming individuals for their health outcomes. So, we really need to look at, what are those social detriments of health and the social inequalities that are part of that, and address things at a system level as opposed to at an individual level.
Thanks, Helen. And Sheelah, I suppose around that, I suppose specifically what, like, when it comes to the socioeconomic inequalities in chronic disease, what do you feel needs to happen next?
Yeah, I suppose we need to just think about it broadly. And I think, again, it's kind of coming back to the data, and it's coming back to the analysis that it's been done. It's kind of been ad hoc, it's particular groups. But do we need a champion of health inequalities? Do we need somebody that is going to take this on and is going to look at the various dimensions, not just, somebody has lung cancer because they're smoked? Okay, yeah, but let's go back further and see what led them to that decision, throughout the life course. So I think we really need one person or one group or a group of people that will come together and, will take this on and, do the research, get the evidence out there. And I think at the moment we're probably missing that in Ireland, just the way things are. But it's not easy, and there's no one, simple solution. It's multifaceted causes, and the solutions are going to be multifaceted as well. So it's a big undertaking, but maybe something like this would drive that on.
So maybe the answer is that national health and equity strategy, Susan, that you wanted as the one big ticket.
Well, I mean, sometimes it's nice at the end to have something concrete that you can work with. I mean, the National Women's Health Strategy has been really successful. Now, I know the current minister is very pro a lot of the women's health issues as well, but the funding, like even like something like menopause. Now, we've just in Deep End got some funding for menopause care at the Deep End. Like, there's so much data. Women in the most disadvantaged areas are way less likely to get HRT than those in the most affluent. So at every single healthcare decision and action is patterned by these inequalities. So we do definitely need some kind of centralized, that requires a commitment, and I'm not sure, a political commitment. Now, to be fair to the former Taoiseach Leo Varadkar, he did set up the child poverty unit in his department, and that is having a really positive impact. But it needs to, I think, you see, people are happy enough to regard children as equal and deserving equal rights. So it's a good place to start, but actually we need to address it for all ages.
Okay, brilliant. And look, I think we could go on here for quite a while, but I'm conscious we've already gone over time, so I better draw the discussion to a conclusion. So firstly, just to say sincere thanks to the three of you for your time today and your input. I thought the presentations were fantastic, and yes, we have a long way to go, but I think it's the only way we can get there is to keep having the discussion and the conversation. So many thanks for that. And I suppose just to the audience to say thank you for joining today, and thanks to everyone who's joined over the course of the 4 webinars in this series. We've had hundreds of people join across the year, so it's been really fantastic. We don't have details on a future series, but hopefully there will be another series coming in the new year, and we'll be back in touch with more detail on that. So again, with that, thank you very much to our speakers today and to all of the attendees.